Did you ever find that you had a patient or a person that you worked with, a surgeon? Did you ever find that if they were handing, we'll say, that they ran into any difficulties with getting the implants stable and in the right position because they didn't necessarily have a system? They didn't make it sort of a boring, sort of diluted down system?
Sometimes, like there was one that his technique was different. Also, different types of surgeons, different techniques. Periodontists are more.
Oh yeah, you had a surgeon that you worked with one time, and didn't he do all 4 sections of the mouth?
Yes,
instead of
at different times. He would do like upper right, upper left, lower left, because it would. I guess it was kind of like cutting hair. Like you cut this side first, and then it kind of like
try to
guide
match
you.
it to the other. What did that look like in terms of the symmetry? And now that you could look back and think towards it, implant positioning, how did that relate to sort of what you would do today? You know, like how would that have affected your job?
How would it have affected my job? Well, like if we're not reducing enough bone, or if like the AP spread is off. Then...
No, I'm saying more like if I was to segment my surgery in that way and didn't have the same system that I did, how would the results change by doing one section completely different than the other in terms of making the teeth?
It would make for probably a lopsided prosthesis, depending on like bone level, how they line
position
it up
of the screw and all of that, right?
Yeah.
I always found that when I was looking, because when you start doing these surgeries, you want to be able to treat them in a very, we'll say, like regal professional type way, right? You put on your white coat and you go, wow, this is the most expensive thing that will ever come through this office, and we've really got to sell the case, and we've really got to break it down, and really have to treat each individual site like it's ready for an implant and all of that. And I always found when I did that, looking at each location separately instead of being global, more intricate in a way. Yeah. When I would do that, I always found that it was really difficult for me to get even the right positioning, but I also found that it was difficult to get even the implant solid, because you would adjust it and say, oh, that's not quite right, and micro adjust it. And by changing that, you sort of loosen the bone that's holding on to the implant. Yeah. And I see when I've trained other offices, other surgeons, other people doing this, one of the first things that I look for is how much messing with that implant are you doing once it's in? Yeah. You know, in our world, you don't cut that hole until you know that that's where it's going to go, because that bone is really important for holding the implant screw. And if you constantly are messing with it and you're looking at it and you're changing it, you can really complicate things, because then you take that smaller implant, which is then wasted because you may not be able to use it. Mm-hmm. You have to get a bigger one out, spend the money on it, getting the bigger one out. Now you've kind of ruined that area of bone. So that's sort of the decision tree that a lot of people go through, I see. And they in essence, they kind of handcuff themselves by overcomplicating it, to me.
Correct. But this was a surgeon, so they weren't dealing with the prosthetics afterwards.
Sure.
So I think that's why it was like, I'll just put this here because this is where the bone allows me to put it. And they were not thinking about, where the screw channel's going to come from. And
yeah, getting the surgery to be boring required a lot of cases and working with a lot of the tooth type side of it, right? Getting surgical results that were boring and getting a surgery that was boring was dependent solely almost upon understanding where those teeth go and what are the things that get in the way, etc.